So let's hit the most important aspects of mood disorders. Starting, of course, with the symptoms. Make sure that you would be able to generate some of those symptoms on those questions that ask you to assess why someone is demonstrating something, especially your low mood. That's your way of saying depressed without saying it, and your loss of pleasure. Remember what constitutes a depressive episode and when it becomes recurrent depressive disorder. Take a look at those. Then, of course, let's talk about the difference between unipolar and bipolar disorder. So, bipolar disorder is an episodic mood disorder, which means you're experiencing episodes of both very low and very high mood. That high mood is that mania. Make sure you can explain or provide examples of those manic episodes. Again, if you were asked to explain why a particular person was demonstrating that in a scenario, you'd want to be able to recognize those. Remember, there's type 1 and type 2. In type 1, you're experiencing mania. In type 2, you're experiencing hypomania. Hypo is that prefix that just means like less than. So hypomanic is a kind of a less extreme version of those aspects above. Remember that this is often assessed by the Beck Depression Inventory. There are, of course, other measures, but this is the one they've most often asked about. Memorize, you got a 21-item self-report. It's on a 4-point scale, but that's 0 to 3. And you're asked for those questions to describe the extent to which you felt that way in the past 2 weeks. Remember that you might have to evaluate that. So take a look at your strengths and your weaknesses there. Most importantly, please remember the difference between reliability and validity. Reliability has to do with consistency of results. That could be test, retest, or split half reliability. Validity has to do with whether the measure is actually testing what it says to be testing or purports to be testing. Now, make sure you've committed a couple of examples of items in the BDI. Take a look at these, pick a couple to memorize, and remind yourself of that kind of format. I would pause this and read what the ICD-11, the International Classification of Diseases, says, especially about culture, just in case you were asked about cultural differences there. And then we'll take a look at our explanations. As with all of our disorders, we have a biochemical explanation. This one is dopamine and serotonin. So generally, we're looking at low levels of both of those as one explanation for the depressive symptoms people experience. Remember that our dopamine is related to our motivation and pleasure. So the symptoms that they experience, like lack of interest or enjoyment in activities and lack of motivation, might be tied to those low levels of dopamine in the brain. Now, serotonin, memorize that SAMA. Generally, we look at low levels of serotonin as the causes for those disruptions to sleeping and eating patterns because serotonin regulates that sleep, appetite, mood, and anxiety. We also have genetic elements, particularly with bipolar disorder. Bipolar is thought to be one of the most likely inherited disorders that the genetic causes may be up to 80%. I'm not going to talk too much about that because your key study from this particular chapter is the Aruch study, and it's all about the genetics of bipolar disorder, and I have a separate video on that. But there are also psychological explanations. You've got 2 of them. Beck created the cognitive theory. In particular, he has that cognitive triad that you can see there. But generally, as with all cognitive explanations, the issue here is some kind of thought distortion. Cognitive is your thoughts. So some kind of thought distortion or some kind of faulty information processing. People with mood disorders, just like people with schizophrenia and OCD, people with mood disorders, when they process information, there is a flaw happening there. They are not processing information in an accurate and healthy way. So he suggests that your mood and your physiological symptoms are likely caused to some extent by that. You can see his cognitive triad there, but basically he asserts that many people have childhood experiences like excessive criticism or abuse or something that plants the seed of negativity that becomes for them a negative self-schema. Your schema is just the way you look at the world. It's like the lens through which you look at the world. So because of these experiences for many people in childhood, they have planted in them that seed that creates that negative schema, and it affects the way that you interpret the world. So because you have those negative views about yourself from the beginning, those negative views about yourself also color your views about the world and then your views about the future. And that becomes a self-reinforcing cycle. Now, he in particular is focused on automatic negative thoughts, your ants that you would want to stamp out in therapy. But if you take a look at it, Beck he does not not assert that it is all just your thoughts. He acknowledges that there are causal triggers, that some people have those biological vulnerabilities, but also that those stressful life events can be causal triggers, those early experiences you see there that I mentioned. But for him, it's your automatic negative thoughts, it's your cognitive distortions, it's that triad, that persistent pattern of negative reinforcing views. All of those help to maintain that depression or exacerbate those biological vulnerabilities. Be familiar with what some examples of these distorted thinking patterns, these faulty or flawed thinking patterns. You may also use or encounter the term maladaptive. We all adapt to our situations through our thinking patterns, but mal as a prefix means bad or poorly. So you've created these thinking patterns that are poorly adapted and thus are harmful to you. When we say they're not rational, we mean that they're not like productive and helpful to you. So if you engage in these, I would memorize a couple of these. If you engage in this type of thinking, it can lead to negative emotional and behavioral consequences. If you're always catastrophizing, if every little setback to you is something that's going to be the end of the world, then it's no surprise that you experience those negative emotions and that you might see those behavioral consequences such as retreating. If you see everything in terms of black and white, if you're always either succeeding and failing, then anything less than success is failure. Obviously, that type of thinking has emotional and behavioral consequences. Now, the other the other psychological explanation is Seligman. So Seligman created this concept called attributional style, and he also gave us the idea of learned helplessness, and those relate to each other. Generally, you want to be able to define learned helplessness without using the word learned or helpless, and the way you can do that is say, all right, well, if I believe that suffering is inescapable, then I'm going to stop trying to resist it. I'm going to stop doing anything or trying to change that. So not trying to resist it or change it, that is that helplessness. But because I've experienced so much difficulty, I start to believe that there's nothing I can do about it. And that's where the depression comes from, that feeling that you don't have any control over your outcomes. And that's caused by having what he called a pessimistic attributional style. You may also see this called explanatory style, because what attributional style is it tells us about the person's pattern of thinking. How do they explain the events that happen to them? The acronym you want to memorize here is, I do GIS. You could also do SIG, whatever makes you happy. But people with depression often show a negative or pessimistic style, a negative or pessimistic attributional style. So when they explain things that happen to them, this is how they do it. When something bad happens to someone, like failing a quiz, for them, it is, if you ask them, why did that happen? It's internal. It's their fault. They're stupid. If you ask them, like, well, I mean, it's just one quiz. No, they view it as stable because the cause was that they're stupid. And if they're stupid, they're going to always be stupid. Globally, you might be like, okay, well, it's just one quiz. But no, to them, if the cause is that they are stupid, then that's going to affect everything. That they failed a math quiz, but now they're going to fail their English quiz too. And they're probably going to do bad on the SAT. So when bad things happen to them, they blame themselves. They think they're going to persist and go on forever. And they think they're going to affect all aspects of their life. Now, when something good happens to somebody with a pessimistic attributional style, they look at it completely differently. If they get a good grade on a quiz, well, that's just because the quiz was easy. And if they get a good grade on the quiz, they're like, yeah, this one, but I'm going to fail the next one. They get a good grade on the quiz, they're like, yeah, this one, but I'm going to fail my math quiz, or my friends are like, I'm annoying and my friends don't like me. They're going to apply it more globally. So if you have a negative attributional style, that is part of the way you explain the world. And listen to what I'm saying. If you explain the world in that way, it's no surprise that you would feel kind of helpless, that you would feel, and that you would show those characteristics of depression. Here's a question from that attributional style questionnaire that he created. For each question, they're given a scenario. You've been unsuccessfully looking for a job, and then they're asked to write down a cause. And then, is that cause due to something about you or other people and circumstances? Is it internal or external? Will it be present in the future? Is it stable or is it unstable? Is it going to influence just your job, or will it also influence other areas of your life? Is it global or is it specific? So you can see this is kind of how the questionnaire he created to assess it. So he wanted to do a more scientific study about it. So he looked at a correlational study. He said, well, is there a relationship between someone's attributional style and their depressive symptoms? So he recruited 39 patients with unipolar depression, 12 with bipolar depression, and then, of course, a non-clinical group of 10 who didn't show any symptoms. And then he gave them both the BDI and the ASQ that he had created with those 12 good and bad events. And he looked at the relationship between it. So he did find that the people with the bipolar and unipolar depressive disorder had obviously more pessimistic and more negative attributional styles. He did find that the more severe your depression, according to the BDI, the more severe your depression, the more pessimistic you were on the ASQ. It's worth remembering how the BDI is scored. Anything over 21 is moderate depression, over 31 is severe depression. This is, of course, going to be out of 63 because there's 21 items on that 4-point scale, 0 to 3. So we looked to see if there would be a relationship between their BDI score. The higher their BDI score, the worse, more pessimistic their ASQ was. Then he gave those patients with the unipolar disorder, he gave them cognitive therapy. And he did find that when their ASQ improved, their BDI score also improved. Now, this is still correlational research. So we can't necessarily say that it was a better ASQ that caused a better score on the BDI, because it could also be possible that it's your depression that's causing you to have a negative ASQ. So he didn't assert causation there, but he did find there was a correlation between your attributional style and the seriousness of your depression. Now, if we take a look at our treatments, we've of course got biological ones and psychological ones. So if we look at our biological ones, remember there's 3 types of depressants to be kind of aware of. You've got your tricyclics, which originated in the 1950s, the first kind of antidepressant that was created. Now, these are the least likely to be diagnosed because they do have more serious side effects, but they may still be if you don't respond to the others. You've got your SSRIs, which are most commonly prescribed because they have the least serious side effects generally. So you definitely want to understand your SSRIs and how they work. The selective means that this focuses specifically on serotonin. So if you look at tricyclics, they would focus on serotonin and norepinephrine and other neurotransmitters. So by focusing on just the one that is most salient for depression for many people, that prevents some of those negative side effects. So the way an SSRI works is you've got your neuron here. You've got your presynaptic neuron and you've got your postsynaptic neuron here. And then you've got the synapse. That's the place where the neurons meet. So the job of serotonin and other neurotransmitters is to carry messages. So they go from this neuron before the synapse to this one. They get received here. So it gets released here and it goes into the synapse and it hangs out and it eventually, some of it makes its way to the receptor in the postsynaptic neuron. Now, some neurotransmitters, some serotonin doesn't make it there. And you have something called a transporter here on the presynaptic neuron. And the job of the transporter is kind of like a vacuum cleaner. It cleans it up because you don't want just neurotransmitters hanging out there. So if they don't get received, they tend to get sucked back in here to the transporter. But what SSRIs do is block that. They block that so that more serotonin stays here in the synapse, which means more serotonin has the chance to get to the receptor and actually act on your brain and act on your mood and act on all those things that serotonin affects. Now, MAOIs work differently than that. So a monoamine refers to things like serotonin, norepinephrine, dopamine. Now, the oxidase is an enzyme, and the job of the oxidase, the enzyme, is to break down those monoamines. So what an MAOI does is inhibit or block the oxidase that's breaking down the monoamines, because the goal is more dopamine, more serotonin. That's all the goal. If we have more dopamine, more serotonin, then they can help theoretically, if you buy the biochemical explanation, then they can help those symptoms. So we want to stop the oxidase enzyme from breaking down the dopamine and the serotonin and the norepinephrine. Now you can see that monoamines tend to have slightly more serious side effects, and there are some special issues with monoamines. They tend to have more interactions with other drugs. They also can have interactions with certain foods. So because of that, the first line treatment tends to be an SSRI, and then if people don't respond to SSRIs, then you might try an MAOI. Now, you also have, of course, some I'll let you take a look at this. If you were asked to evaluate the biological treatments, all of them have been proven more effective than placebos in large clinical studies. We do have 50 to 60% of people that show improvement in those 4 to 6 weeks. Of course, some individuals respond better to a certain drug, and we do have some evidence that these drug therapies work better for moderate and severe depressive disorder than mild. So mild depression tends to be better perhaps treated by a psychological therapy. Speaking of, there's 2 in particular psychological therapies that you should be aware of, or psychological treatments you should be aware of. The first one, because it kind of came first chronologically, comes from Albert Ellis, and that's his REBT, Rational Emotive Behavior Therapy. Now for this, you want to memorize your A, B, C, D, E, although D and E are the parts that actually treat. So he recognizes his theory, and this is one on which Beck's treatment also depends. It's the idea that it is your thoughts that are causing those negative consequences, those negative emotional and behavioral consequences. So by changing your thoughts, you can prevent some of those negative symptoms. Now, Ellis in particular, it was influenced by Stoicism. It was his belief that people are actually more affected by their own perceptions of the events than the events themselves. It's not necessarily the bad things that happen to you, but the way you perceive and react to those things. So in his model, you have an activating event, something that happens in your life. And then you form beliefs about that event. And for him, those beliefs you form about that event are what need to change. That's what's causing it, because those beliefs, those cognitions, those beliefs are causing you to experience those negative consequences, those emotional consequences, those behavioral consequences. So the treatment in REBT starts with D, with disputing. So your therapist is going to teach you to forcefully question or dispute those irrational beliefs. You're going to change your thoughts because, again, it's your beliefs, your maladaptive beliefs and thoughts about the event that are causing the problem. So once you learn to dispute those ineffective or harmful or irrational beliefs, you're going to feel the effects of a new belief. You're going to have an effective new belief that's formed that is going to change and help to address those symptoms. So there have been example studies, of course, suggesting that this works. REBT has been proven to work better than a baseline or a control group, and it's been shown to be equally effective compared to antidepressants. If you take a look at this, you can pause it. You might find this helpful. ABCDE is as far in this as ACE tends to ask, but it's worth reading about a secondary disturbance. That's the term that he uses when he writes about it. Then finally, we have the Beck's cognitive behavioral therapy. So it's kind of confusing because we talk about CBT for several disorders. We talked about CBT for schizophrenia as a treatment for schizophrenia. We talk about CBT as a treatment for anxiety and phobias. There's a version of CBT for OCD. But like the concept of CBT is really like an umbrella, and it's focusing on that relationship between our thoughts and our behaviors and our emotions, and looking at how we can change our cognitions. That's cognitive behavioral therapy, and how we can make changes to our behaviors and how that can help to treat and deal with the emotions that rise. Now, specifically, when you write about this in terms of mood disorders, you're going to write about something called cognitive restructuring. And that is Beck's specific treatment for mood disorders. So recognizing and challenging and replacing those maladaptive thinking patterns that we've developed and those automatic negative thoughts. Think about what automatic negative thoughts means. Like it is not even conscious. When something bad happens, your immediate automatic unconscious thought is, well, that's because I'm stupid. That's because no one likes me. That's because this. If you are constantly jumping to an automatic negative thought without even being aware of it, well, of course, there's going to be those negative behavioral and emotional consequences. So for him, Instead of focusing on the ABC, he looks at, like we said, those ants, those ANTs. We're still recognizing irrational and inaccurate beliefs. We're still catching them. We're still challenging them. But for him, it's more of a focus on helping the patient see the link between those thoughts that they're having and those behavior and emotional consequences, helping them to understand and reattribute those problems and failures, which brings us back to kind of attributional style, that underlying, and reframe their thinking. There's been research too for cognitive restructuring, of course, proving that in this case, that getting cognitive restructuring and antidepressants was 3 times more effective than just receiving antidepressants. So for REBT, we're thinking about that ABCDE. For cognitive restructuring, we're thinking about those ants. Now, if you want to take a look, here is a T-chart I created to kind of help you distinguish between the two. They do have similarities for sure. All right, I hope that helps. I hope you feel better about mood disorders.